Okay, let's bring the panelists up. Panelists for this are Sean, Dr. Lee, Dr. Stillman, Dr. Vogel-Claussen, and Dr. Wang. And we're going to start with one audience question. I'm going to log in and vote. So get your phones out. Okay, so over the next 5 years, do you envision low-dose CT for lung cancer screening? Primarily keeping its focus on lung cancer, slowly integrating additional screening elements, rapidly expanding into a comprehensive multi-illness screening program, or becoming totally bogged down due to costs, litigation, technical challenges? That's a tough one. Tough question. Well, it looks like we're leaning towards slowly integrating additional screening elements, with a second being what's number 2? Can't tell the colors. Rapidly expanding. So it's either slowly integrating or rapidly expanding. Interesting. Panelists, do you have any thoughts on that, by the way? Do you think this is going to happen quickly? There's going to be, we're just going to slowly integrate. We have the big 3. There's going to be a big 4 or a big 5, and they're going to come along in the next year or 2. Or every day I look at the radiology literature, there's another article on, we can predict, whatever, hair loss. We can predict, you're going to die. We can predict. I mean, literally every day you look at a journal, there's another prediction rule. So is this going to explode, or is this just are we going to move this really slowly? What's your thoughts?
I think I voted for slowly. In Germany, at least, we're focusing on lung cancer screening because there's different level of evidence, right? The authorities check the level of evidence, and they're luckily, through also in the audience participants, we have enough evidence for lung cancer screening, but we do not, as already been alluded to, have enough evidence for the other 2 of the big 3 to be implemented in a program. So we need to do our homework first and sort of then convince the payers to pay for it if we show the evidence. And that takes a little bit more time. That's our approach, at least what we do.
Any other thoughts from other panelists? Or
yeah, I guess, I mean, I feel like coronary artery calcium has got potential, right, for a manageable therapy. Can you hear me, by the way? Is this working?
Boy, we're not doing great with microphones here.
Yeah. Anyway, I feel like the coronary artery calcium has an actionable, potential intervention, so that might be incorporated more quickly. Emphysema, what do you do about it? And I think that needs more evidence to decide how to manage or change management if encountered, and how it interacts with the lung cancer progression.
So if I may, I'll do a bit of a different perspective on the calcium scoring in the lung screening population, because
microphone.
Roughly 3/4 of patients in the lung screening population would be considered for statin therapy to begin with. And the real decision to be made is not whether you're high risk, low risk, or intermediate risk, it's whether to treat or not. And so, so if you have 3/4 of them who would already be treated, and it's only the intermediate risk group that's recommended by the guidelines to get calcium scoring, And where the calcium scoring has a major effect, because you don't get a major effect for low risk or high risk, most of them are going to be either, will have either a calcium score greater than 100. So they'll have that intermediate risk and be treated. So the question is not high risk, low risk, or intermediate risk. It's treat or not treat. And most of the lung screening population qualify by guidelines for treatment. And as Matthias says, right now, the treatment right now is very cheap.
So you're basically saying is we have to take this information into action now. That's what you're saying.
Well, no, I'm saying if you're in a lung screening program, you probably already should be on statins.
Yes, but if you're not, and we're going to hear soon about the medical legal stuff, if you're not on statins, and you should be, there should be something in the chart that says this was discussed, this, that, the people are aware of it, or et cetera.
Yeah, and I'm going to make a rule. Everybody who's speaking, really concentrate on speaking into the microphone because we're just having too much difficulty hearing everybody. Go ahead.
Yeah, I saw this in our review paper as well, and there is no at the moment, if you follow the ACC guidelines, there is no automatic way if you see calcium that you that's a pathway 1-0. If you have calcium, you take statins. If you don't have calcium, you do not take statins. It needs a blood test evaluation and a cardiologist evaluation in between. So at the moment, at least, a speaker this morning said this correctly, that at the ACC guidelines, the calcium score is viewed as a test down the diagnostic pipeline when the physician is unsure. So it comes further down on the diagnostic pipeline in the unsure cases. But here we change a paradigm. All of a sudden, we're at the forefront of a screening test, which comes for free in a vulnerable population. So it's a game changer, and there's no guidelines for that. There's no guidelines for that currently, and we need to provide the evidence. That's what I meant with the homework we have to do. In the Hansa trial, I just have to say this quickly, we randomized reporting. So half of the people got reporting the calcium score, the other half didn't. And the calcium score higher than 10 was recommended to talk to the GP about their cardiac prevention or cardiac health. Because we discussed actually very controversially whether we should put the word statin in there. We didn't, because it's a very hot debate among cardiologists what to do about that. But I think it will evolve rapidly in the future, and the guidelines will probably change. And I think we are part of the change.
I'm going to change the topic a little bit because recently, people were talking to me about the poor uptake of lung cancer screening in the United States. You know, that it's still, with everything that's been done and commercials on television, that we're still talking about a 15% uptake, maybe some places a little higher. And the rate of follow-up screening is even substantially worse. You know, maybe 20% are actually getting their annual repeats. And when you talk about 3 rounds or 4 rounds, it's terrible. And what they said to me was, you know, we just need a couple of more good lawsuits to, you know, where physicians are going to get sued for not recommending screening for their patients. And that's the only thing that's going to make lung cancer screening happen in the United States. Now, I don't know if Europe is going to be the same, but I want to extend that because now this is a session on comorbidities. What's the situation now where we have a person, we do a CT scan, he has obvious osteoporosis, and we don't, and it's a lung screening, and we don't say anything. And then a year later, he comes back with 3 collapsed vertebrae, and he says, "How come you didn't tell me? You know, now I'm in agony all the time." Is this something that's going to start leading to lawsuits? Now, we're fortunate that we have We have an MD/JD in the audience who is expert on this and is just waiting for that one case to come along so he can officially set up his class action lawsuit. Dr. Goldsmith, can you tell us, this is coming, I think, all these incidental findings that we have, when are we going to get in trouble for not reporting them?
I don't think we're going to have much of a problem in the long run for a number of reasons, and I've been giving a lot of thought to it. One, when a lawsuit occurs for failure to diagnose on one of these scans, one of the problems is the statute of limitations in many jurisdictions, which will have elapsed before a lawsuit could be brought. In those jurisdictions where it could be brought, such as in the state of New Jersey, the problem is that once the lawsuit is settled, because the lawyers are rather avaricious, there's confidentiality. So the information doesn't even get disseminated. So while I've seen a number of these lawsuits and participated in them, I don't see the information being disseminated and creating much of a risk. I think it's more incumbent on your end professionally to make sure that the information is collected and properly disseminated. But I don't think litigation is going to enter into and become a major problem.
Well, but just on a more theoretic basis, when do you think of the physician having a liability? It's a lung screening test. Osteoporosis is not the main thing on his mind, but when you look back at it, there's pretty serious osteoporosis.
No
there.
question. I think that the physicians ultimately may have liability. There's the potential for liability, but will it go from liability to litigation to ultimate result? And that's where I've been thinking very seriously, sitting at the meeting here, about what sort of class actions could be brought. And I intend to try to put this together in a paper to disseminate it after this meeting. But I think class actions are possible, but I think it's far more important and incumbent on us, because I have both degrees, as physicians, to make sure that the information is disseminated appropriately and treatment is encumbered. Litigation will not be the answer. Better medical care is. That's my response.
Dr. Henschke, you look very
Yes.
perturbed by this.
So to not in the US, the College of Radiology says you should report all findings. So I'm surprised. 11 reported Lee that the radiologist is supposed to report all.
Okay, to take a look at it, the radiologist should report all findings, period. But let's go to the point in saying, okay, the radiologist did not report the finding. That finding is now created a problem 2.7 years afterwards. In the state of New York, you could not bring litigation because there's no discovery rule. The statute of limitations will have expired. In the state of New Jersey, you could. Will that occur in New Jersey? Will it occur in New York? Will it occur in California? Will it occur in another state? The obligation, my feeling, is on the physician to report all findings. Now, the very first case I ever got involved with a lung cancer case, probably about 30 years ago, a patient went into the emergency room of a hospital, a chest x-ray was done, a nodule was found, the patient was discharged from the emergency room, the report went to the file room, and he was never advised of it. A year later, he was diagnosed with lung cancer. The widow ultimately brought litigation. So that's totally a lack of communication within the information, with the information. The number of suits for failure to properly send a patient to a practitioner when you have it, the failure to get the screening done, are very limited. I know of 2 in the state of New Jersey, both of whom were settled with confidentiality. With confidentiality, that information is not disseminated, and physicians don't respond because the insurance companies do not send out the information. So what should be done morally, ethically, and professionally is one thing. What we try to do legally is another, and they don't necessarily mesh, and they don't
You keep away
necessarily
from the moral and
incentivize.
ethical stuff.
Huh?
You keep away from that moral and ethical stuff.
I don't.
Okay.
Thank you.
Let's, Jim, do you want to ask some other questions to our panelists?
Thank you. So the coronary calcium stuff, I think, is not well resolved at this point. And I think we can discuss it further. But the emphysema thing is worse. Okay. Because the emphysema, the conclusion is there's no treatment, therefore we don't have to tell them. That's wrong. We have undisputable evidence that the degree of emphysema correlates with the degree of lung cancer risk. And if somebody is still smoking and they had emphysema and they have no symptoms or anything else, which 85% of them in screening will not, they wind up with the lung cancer and they say, gee whiz, if you had only told me, I would have stopped smoking. I mean, there's all kinds of things like that. There's a wonderful experience from Milan, in which a greater emphasis on smoking cessation actually is resolved in a much better adherence and uptake and stuff like that. So, I mean, there's a lot of dynamics in this that are actionable.
Yeah, preliminary, I can say we did a smoking cessation intervention in the Hansa study. And as you know, half of them we showed the emphysema and the other half we didn't. What we didn't think of is that smoking is an addiction, right? You may show them the lung destruction, right? But if it's not an intensified smoking cessation program, the addiction overrules. So we had only minimal increments on smoking cessation. This is just preliminary.
But that's your experience in Germany. In Chicago, my colleague, Mary Pasquinelli, who's been running that center for a number of years, when they go through the findings of emphysema on the scans with the people seeing the actual images, their uptake with smoking cessation is much more favorable. I mean, I don't think this is a settled matter. And are there others on the panel that want to comment here? Sean?
Yeah, I just, coming from the perspective of chronic lung disease.
Take the other one.
Coming from the perspective of chronic lung disease, earlier intervention is better, right? And I'm wondering a little bit about whether we're kind of flipping this discussion to the wrong, okay, it comes along with lung cancer. What about the idea of, hey, we're picking up chronic lung disease much earlier. Can we intervene to help prevent progression of that? And especially if you have asymptomatic individuals and you're catching the disease very early, there's a potential that an intervention would prevent the more severe outcome. And I'm kind of curious about that opportunity.
Anybody want to comment on that? Yes.
I'll comment on something a little bit related. So we had an engineer from Siemens who visited us when we had installation of a new scanner. He was a chain smoker, and he volunteered to have a coronary calcium score as a test. And he promised me if he had coronary calcium, he would quit smoking. He had 0 calcium, but it turned out he had an abdominal aortic aneurysm. And we don't really talk that much about this, but peripheral vascular disease is highly associated with smoking. And I even would wonder if part of our CT screening should include, at least on the initial scan, an abdominal portion to look for some peripheral vascular disease.
Dr. Wang, do you have any comments on this?
Thank you. I think from thoughts to practice, it takes time. And the breakthrough is a good idea, a great idea, but we still need more evidence, especially the cohort follow-up evidence, and then go to the guidelines, tell people if the patient underwent the scan and found the lung nodules or calcium score, how many months or years should he come again? And do what? Do low dose or do the conventional scan, or need to combine a coronary CTA or cardiac MRI? So we need to tell him more things and collaborate with the physicians to tell them if they need any treatment. So there's a lot of things to do. And then we need the policy support, like in China, and the cost of the chest CT is very cheap, 200 RMB for each chest CT. And if we give them all the things at the report, we need a long time. So if we can apply for a new, how to say, the policy for the screen at a relatively higher price, then we can give them better the service to the patients.
Yes, and so I appreciate what you're saying. But yesterday, Dr. Yankelevitz pointed out that if you come to the ER and you get an X-ray and they find an incidental nodule and the nodule turns out to be cancer, no one argues about it, they just pay for it. Now that when you're aware of it, you have to deal with the consequences. Well, for the cardiac thing you just mentioned, there are already guidelines for when the various steps should take place. And because you get screening, you're not absolved from the already recommended guidelines in this age group that are already worked out with thousands and thousands of people and evidence. And the American College of Cardiology, the American Heart Association already has addressed the things that you are concerned about. Now, that's in the United States. But the point is that when you become, the difference between, a lot of people commented, the U.S. Preventive Services Task Force says don't screen for COPD. Well, that's one situation. You've already got the CT scan. You already got the emphysema. That's a different situation. Yes.
Yeah, you're making a very relevant point. But yesterday in the talk was that it's not only in the emphysema which makes the diagnosis of COPD, right? It's the airflow limitation and the dyspnea and symptoms. And in Germany, I think, I'm not a pneumologist, but they tell me recently, if you have emphysema, you have a COPD. Maybe we need to change the name COPD into or smoking related or emphysematous lung disease, because it's clearly, right, smoking related. Emphysema is part of COPD, but it's sort of been pushed up in the diagnostic algorithm recently in the GOLD criteria, but it's not a standalone diagnostic tool to diagnose COPD. And I think this group could come up with emphasizing that emphysema is part of the smoking-related disease of emphysema/COPD, and we should, as again, like the coronary calcium, we're at the forefront, right, of the diagnostic algorithm. We're at a screening tool now, which we weren't before. So not downstream measure, but an upfront measure. And we should develop a diagnostic algorithm, for example, at what threshold we should recommend further follow-up for further testing of a full diagnosis of COPD. And a second point, if I may say, and we said this, use it as a teachable moment to enhance smoking cessation. But again, we need to do it intelligently, and it apparently has more effect in the US than with our clientele in Europe, and we need to exchange ideas. Maybe there are little differences in the workflow you had with your results than with our results, and I think little information and harmonization of the workflow in combination, smoking cessation and lung cancer screening, will have then a bigger effect, and incorporating the information of COPD. I think there's a lot of work to be done, and I think we're in one boat. We want to be more effective, and we want to move from early detection to disease prevention, right?
Yeah.
So I agree with a lot of what you said. However, there's millions of people that are going to be getting lung cancer screening over the next couple of years across the world. In the United States, the degree of obstruction for women and for Blacks is different than the reported populations. So that the traditional reliance on COPD criteria is not as relevant. So, you know, as with Southeast Asia, as with other places, there's going to be nuance related to the region that these findings occur in. You wanted to say something?
I would like to stress that in CT, you see the density. You don't see the function. So I would really suggest if you see emphysema in CT, then you should really refer to a lung function test and to a clinical testing to determine how important and relevant it is for the patient. Yes.
We have another pulmonologist has awoken. Go ahead, Luis.
Oh,
We had Luis Sejo.
yeah. Dr. Al-Qaeda at our center did her PhD on this and her thesis, and she looked, we do full pulmonary function tests on our patients. And so you see the heterogeneity of COPD in this population, the screening population. We see patients with low diffusing capacity, and that's the only finding. So normal spirometry and normal plethysmography. And then we see the mix. So we see the abnormal spirometry with the low diffusing capacity, and then you see the pure COPD, so the abnormal spirometry with normal diffusing capacity. So you see the heterogeneity, and this is not easily predicted by CT because you see the emphysema. You can see the wall thickness in the airways, but measuring the pulmonary function is critical in these patients, I think, and we have advocated for that for a long time. And in our national pilot, we're doing at least spirometry in all our patients. So I think that's a critical element, even though the WHO doesn't recommend screening for COPD with spirometry, which is a completely different animal in terms of screening and how to move forward. So this is a very controversial subject. And, you know, this is an underdiagnosed disease, and symptomatic patients get diagnosed with lung cancer, and 60% of them have COPD, and half of them don't even know it until they get diagnosed with lung cancer. So it's a very tricky issue. How much do we report, and what clinical implication this has? And if you don't measure the lung function, you won't capture the heterogeneity that is inherent to the obstructive airways disease and the
There's lung
emphysema.
function and there's lung function. Spirometry is not what you call the best test out there.
That's right. That's right. This oscillometry is one, so you can do that. But you need to see the perspective from a pulmonologist is this idea that diffusing capacity is vascular disease, pulmonary vascular disease. And we see this in smokers, pure vascular disease almost, without the airway implication. Or you see the mix, or you see just the airway implications without the vascular disease.
So from COPD, Gene, the overt emphysema is actually a later stage, and air trapping and airway disease is something that occurs much earlier in the disease process. So there's the potential, if you see emphysema, that things have gone fairly far along, and spirometry being as backward looking as it is, I think imaging might in many ways be a better indicator of loss of function. Yeah.
I need to make one point, as we know each other from functional MR imaging, and we both do xenon enhanced imaging, and we both know that, and we recently did a study. We had exactly the group Lewis said, low diffusion capacity, but no emphysema on CT. And pulmonary hypertension. We came from the pulmonary hypertension angle. And my pulmonary hypertension physician says, this is a new pulmonary hypertension subtype. And I said to him, no, let's test that. It's probably the vascular variant of COPD, because they were all smokers, and one had like some inhalation of some metals, hot metals, right? And we could prove that with the xenon MRI, there was already destruction of the alveolar microstructure. And indeed, we're suggesting doing further research that this might be the vascular phenotype of COPD. And I think the research goes on, and COPD is evolving, and I think we can influence the field from the screening angle.
Mario?
Yeah, thank you. Yeah, my comment goes in directly to that topic, because we know that active smoker actually might have emphysema quantitation biased by inflammation, right? So that's the very early phase, and the vascular component becomes quite prominent, because in those areas with hypoxia, actually vascular constriction happens. And that's the preliminary phase of emphysema, isn't it? So that area of prevention of emphysema, of definite damage, is an area where we still do not have a CT metric to work on. And the LCO is indeed probably the pulmonology weapon to help us working on that. We do not really have an idea of how much of this bias in active smoker is hiding emphysema formation and progression. We do know then that when active smokers stop smoking, the emphysema quantitation increases, right? But we do not know which is the size of this problem to date.
Okay, so we have a problem in the pulmonary area because the disease is defined by the test, not by pathology or something else like that. And the tests are all heterogeneous and this, that, and the other thing. And we're finding out the progression is very variable. And, the ALA with NHLBI is doing these natural history studies to try to sort this out. But we have people coming each day, and there's some simple things like how many people come for screening who have any of these questionable things, have been vaccinated for pneumovax and have seasonal vaccination for influenza, have basic pulmonary hygiene stuff like the benefit of pulmonary toilet, the benefit of physical activity is not defined in this population at all. There's no systematic studies. There's not even a study that you can say, is bad. There's no studies. And so there's an opportunity for this early stage of disease. There's a vacuum in terms of interventions that you could do. And I'm not just talking about lung reduction, but a whole variety of things in terms of just straight preventive medicine that's already recommended in this age group, and it's not being applied.
So can I
think
let me say something. So when we read a screening CT, we put recommendations for each of the findings. If we have liver, if the liver has low density, we say see a liver interventional person, and we coordinate within our hospital with those specialties so that we know who to send them to. So I think that at least reporting that there's some finding. We've done studies on each of those things that we make recommendations for. And I think that's something that you have to do in a screening CT.
I think that's starting the right direction, but like in the primary care versus cardiovascular management thing, the issue of who manages statins is a real problem, because basically the cardiologists say for basic statin management, you don't need to see us. We already got our guidelines, and the primary care community can do those things. So I agree with you. Systematically pulling these things out and getting them back to the right referral population is great, but we just can't have referral to subspecialists. The primary care people kind of have a role here that we got to engage more carefully.
Studies, not in cardiology, but in the other findings, the liver function, pancreas, all of those findings, we've had publications on them. There exist, not only from us, but from others. So really, I think the final message should be, they should be reported in a screening CT. I don't know what the consensus is, but I think they should be reported.
I want to,
Need more discussion here. I think we can draw a very important conclusion that COPD is not the good terminology to describe all the underlying diseases. I think in the COVID period, we were dealing with a disease that was a systematic microvascular obstruction, and it was treated like a pneumonia. So the whole concept, how this works, is not really covering all the diseases that are underlying under those terminologies. And terminology matters, I think. So the word obstruction is not seen on the CT that we make. Obstruction is something that is functional, which is not visualized on the CT. We should state that, I think. So we can never cover with our screening methodology the O in COPD. So that's I think one of the things we should, we also published this in a white paper, and we made that discrimination already. So now we are focusing on the three diseases: emphysema, calcium, coronary calcium, and of course the lung cancer itself. And that should be clear. It's an overstatement if we say that the COPD is also covered, I think, by this way of screening. It's an overstatement. We don't do it.
You know, it was brought out yesterday in some of the conversations that even amongst the high risk for lung cancer patients, the cause of death in the majority of people is not lung cancer. It's their heart disease, it's their COPD, it's their lung disease. And, you know, at one of our prior conferences, Professor Hilton brought out that we should be thinking of this as the new era of preventive health that we're now in. And it really is, you know, and, you know, sort of the way we've been sort of pressing lung cancer screening and, you know, in the US, we're doing it for free. We're trying to make guidelines and we're getting a 15% uptake with, you know, with a much poorer rate of follow-up. I mean, it's really pretty terrible if you ask me how it's going. And, you know, people can talk about it, but why aren't we talking now more and more? The Rubinska study is going to come out and show that by tomorrow we'll have those results. We missed it by one day, I understand. We'll show that the CT is going to be the best predictor of coronary calcium. That's going to be better than any other guidelines. So we're going to have that guideline. Everybody's going to be told to get their Pneumovax vaccine when they have, you know, emphysema on their skin. I mean, it seems to me that this is going to be perhaps the best solution, that we should start thinking of this again. And we've always talked about this as, you know, this is preventive health. This is fundamentally preventive health now. It's not just lung cancer. And we've got to really, I think, start moving in that direction if we're going to really get, you know, patients to fully buy in that this is their overall health. It's not just lung cancer. You seem eager to say something.
No, your mucus plugging, your bronchiectasis.
Yeah, all of that. And I think that's, you know, ultimately that's going to be the way that this is going to become successful, that this is, you know, a main part of a person's healthcare. These low dose scan of the chest is going to provide more information than a doctor's visit and him poking around and, you know, palpating and whatever. I mean, provides a lot of information.
We have a gentleman who's been waiting patiently.
Yeah. So I thought I'll jump in here a little bit because I concur with the need to report everything that you see because that's the role of the radiologist. What I see in reports in Singapore is that we often have, let's just say it's a mammogram. It comes at the bottom with a BI-RAD score. And now with the thyroid ultrasound, it also comes up with a thyroid score at the bottom of our reports. So I think that's the standard that radiologists, and that will then move the paradigm because based on your classification that you establish through the evidence-based research that you're doing so extensively here, you could then modify that criteria as international consensus and have that attached to the end of the report so that it cues whether it's a specialist or whether it's a general practitioner. They will then take the cue based on the standards that you have. So I think that's probably my input. Thank you.
Yeah, hello. Yeah, I'm agreeing with Matthias. I think we need to coordinate that. Claudia says she reports everything. Matthias says probably we need to focus on the big three. And I think we agree with each other. There are comorbidities which are very common, right? like coronary calcium and emphysema, because it's part of smoking-related diseases, and maybe osteoporosis, right, which is very common, and liver disease, and when we go down, right, we discussed that fibrosis. Fibrosis is yeah. Fibrosis is also very common, and smoking is a predictor for fibrosis in the future. So we need to agree on what we harmonize, screen for, and do structured reporting of. And I think we agreed on the coronary, and we need to convince the payers with more evidence, right? Because they only pay what where's evidence is for. We start agreeing on the emphysema, and we're talking a lot about the bone mineral density and about the liver, maybe very common. And these makes it already 4, and 5 is then the lung cancer we're looking at. And I think this group should maybe discuss this and make recommendations on an organized fashion to report those in a structured manner, and everything else is really up to the discretion of the radiologist, because he or she is responsible still for the report. And we also here should make guidelines similar to the ACR or the ERS to sort of have thresholds to report, because there is one difference between the hospital patients and the screening population. They're healthy. They're not in the hospital, and they would have not gotten the CT if there wouldn't be a high risk for lung cancer screening, right? And we must prevent unnecessary intervention to increase the harm and healthcare cost, because society will then say, okay, we are treating, and we must remember this, we're treating and we get the Porsche treatment for a subpopulation with smoking related subpopulation. So there's an ethical question in that. Standard of medical care. And I asked in the audience the radiologists now, who is reporting the bone mineral density on your regular CT scans in the hospital? Exactly. But also on the non-screening ones? Okay. But on the non-screening ones, that's my question, because you can do, and with a dual energy CT, you can do virtual native scans, so that there's a technical feasibility. What I'm alluding to is the current standard of radiologist reporting or standard of medical care, going to the legal person's comments as well. So this will evolve. Our standard of care has been evolving over the last decades.
Yep.
So I'm sure with AI, this will evolve too, and we're just moving along on that way, but we have to do it sensibly.
Yeah,
That's
but
what I want to say.
you know, all this exists. There is already guidelines for osteoporosis in the United States. It's already reimbursed. And because you got a screening CT, you're not absolved from those guidelines. And Dr. Lee has been very patient, and we haven't heard from him yet. Did you have a comment you wanted to make?
Thank you. I think the of each comorbidities vary across all countries. So I think that in Lodover City, we focus on big 3 disease because in my country, some have some special unique situation. We have national government institution control the all cancer screening program. So we Lodover patient perform the Lodover City. They almostly perform abdominal ultrasound and EGD for screening of stomach cancer and liver cancer. So I don't think that Lodover City can do all of screening of all disease. So I think focus on big 3 disease in low dose CT is more feasible for some countries.
Thank you very much.
So,
Go ahead, Joe, please.
so Dr. Lee had the last word today.